who are here in the room being served lunch, and welcome to those of you who are joining us online. My name is Holly Fernandez Lynch. I'm an assistant professor in the Department of Medical Ethics and Health Policy, and I'm also the REPS co-chair along with our department chair, Steve Jaffe. Today, we are really excited to welcome Dr. Elinore Kaufman for a discussion reflecting on research ethics and policy issues arising in the context of her work that focuses on reducing harm from firearm injury. I'm just going to say a couple of words, by way of housekeeping background, and then I'll give a little bit more robust introduction to Dr. Kaufman. So our upcoming REP speakers through June is available on the Department of Medical Ethics and Health Policy's website. Next month on April 12th, we'll hear from Sneha Dave, who is Executive Director of Generation Patient, and she's going to be presenting on including adolescents and young adults in clinical trials. I will also flag for you on May 10th, we are canceling REPS in lieu of the Renee C. Fox lectureship, which will be a lecture from Dr. Jason Karlowicz, who has a secondary appointment in the Department of Medical Ethics and Health Policy and is an expert in Alzheimer's disease research. So if you have suggestions for people that we should consider inviting, especially individuals from diverse backgrounds and who would contribute diverse perspectives and issues relevant to research ethics and policy, please send their names my way. Quick reminder. Where am I pointing?
We're so worried about the it kept working until right now.
There we go. Okay. Just a quick reminder of some online resources that our department has made available, including a series of short research ethics courses that are available for free continuing education credit. Some of these can also be used to satisfy the Penn and CHOP research ethics training requirement in lieu of the city training. And then, of course, thank you to the REPS co-sponsors, all of whom that you see here. And thank you to Lisa Bailey, our fearless REPS coordinator, for making sure everything moves smoothly. All right, so our introduction for our speaker today. Dr. Elinore Kaufman is Assistant Professor of Surgery in the Division of Trauma, Surgical Critical Care, and Emergency Surgery here at TSOM, and she provides clinical care both at HUP and Presby. Her research focuses on reducing the harmful impacts of traumatic injuries on individuals and communities. She uses quantitative, qualitative, and geospatial methods to evaluate the impact of public policy on injury and injury-related mortality, as well as to study the quality and outcomes of care for traumatic injuries. So we're thrilled you can be with us today, Elinore. Just a quick word about how we'll handle questions and discussion. Dr. Kaufman will pause at a couple of points to invite questions. Those of you who are online are welcome to post your comments in the chat and I can read them, or we can unmute you and you can read them yourself. And we are recording today's lecture and it will be posted to the department's website. All right, with that, the floor is yours. Thank you.
So I realize, is it important that I stand near the mics for your recording or anything else?
No, I think you're close enough.
Okay, because I realize like it's fine that there's like not presenter mode, but I really, when it's really behind me, I don't know what I'm supposed to be saying. Anyway, thank you so much for having me, Elinore Kaufman. Like Holly said, I am a surgeon in the Division of Trauma here, and I'm going to do these disclosures out of order and say I'm really not an ethicist. I am flattered to be invited, and I'm going to be talking about like some stuff that I think is interesting and that has some ethical components, but I sort of tried to do some background ethical reading, and then I was like, this is fake, and I'm never going to get there. So there may be things that I'm going to say that have like really obvious ways that I should be thinking about them, or not. Anyway, help me. Like I need some help on some of these. I'm serious, especially like the first one, but also some of the others. I don't have any financial conflicts of interest, except maybe, which is one of the things I want to talk about. But I have some research and program funding in this area that I hope is not conflicting. And I do sort of have started adding to my talks that I have what I think is an evidence-based belief that the risks outweigh the benefits when it comes to living with firearms and communities. And I know that people disagree about that, and I think there's more and less reasonable ways to disagree about that, but I think it's fair for me to tell you that it'll sort of shape the way I think about some of these things. Although it's also irrelevant to the way, to a lot of what we should do for prevention, I would say. Anyway, so I really just came up, that was supposed to appear later, whatever. There are a few things I'd like to discuss, and I'm gonna kind of go through them, and yes, please feel free to weigh in as I go, and I'll try to pause like at the end of each little area. So what the first thing is, like, literally, like building a career and success of some kind, ultimately off the suffering of other people and specifically marginalized people. And I'm really interested in what the purview is of the health system in addressing, for me, firearm violence, but also other public health challenges and kind of where our boundaries are. Interactions with law enforcement in the sort of individual and in the policy space are really important in this area, and I think pretty challenging, at least for me. I think there's an interesting tension in my work between sort of addressing the root causes of the problem versus addressing in the immediate time frame the people who are most at risk of involvement in violence. And then I have some research that I'm working on that I think is potentially ethically interesting that I'm going to try to share with you and get your thoughts on. Those are projects that are like in their earliest stages, so weigh in now on social media and violence prevention, and on potential role of guaranteed income for firearm injury survivors. That's supposed to say, you know, whatever other people want to talk about. Because I'm not really planning to talk much about research funding or firearm marketing or firearm legislation, which are all complicated, I think, foreign policy issues that are worth talking about. Or this is a thing that some people also like to talk about. I don't have a ton to say about, but about physicians' role in individuals' access to firearms, a lot of things. So I'm also not really planning to talk about firearm injury epidemiology today, but to get a little bit of a same page, I will say a few things. There's about 40,000 deaths per year in this country related to firearms. About 60% of those are suicides, which I think not everyone knows is a really important thing, which accounts for more than half of all suicides. It's a minority of suicide attempts, but it's a very lethal means, right? About 1/3 of the deaths are homicides, and that's more than 75% of the homicides that occur. Firearms are now the leading cause of death among children, full stop. And firearm injury deaths, I don't know how we rank these things, but there's a massive racial inequity, particularly in interpersonal violence, which affects Black people, specifically young Black boys and men, about tenfold more than anything else. More than twice as many people who are injured survive than die, and that's my business, trying to keep people alive, in part, right? But the consequences can be lifelong in terms of physical consequences, but also emotional, social, economic consequences. And just one minor example of that is that about 50% of people develop depression or PTSD on par with the experience of military veterans. Right? And this is just one of those international comparison graphs with the legend hiding in that blue bar. That's annoying, sorry about that. So the total bar is homicides in all these different countries, and the blue bar is non-firearm homicides. So we're like a little bit off scale from comparator countries when it comes to non-firearm homicides, but it's really the firearm homicides that puts us into a totally separate category from a sort of assortment of countries that you might or might not want to be compared to. And I did say this, you know, there's not enough research in this area, but these are some pretty good studies that have accumulated over the last couple of decades. So having a gun in the home doubles your risk of homicide, triples your risk of suicide for the person who owns the firearm as well as anybody else who lives there. Makes you 5 times more likely to be shot in an assault, either by the gun that you have or because having a gun in a situation tends to escalate the violence in any situation. And increases the risk of intimate partner homicide by 7. the main reason that people cite for owning a firearm is protection. People also own firearms for hunting, for collecting, for sport, for different kinds of reasons. But the most common reason people cite is fear of other people. We all think we're above average drivers. Actually, I don't think I'm that good at driving. I think I'm an adequate driver. We all think, many people think they're going to be able to use their firearm to effectively defend themselves, and it's just not there now. Research-wise, so this is an important problem, and these are the sort of research numbers. The top one is funding compared to mortality rate, and we're way off the curve. Falls, which is another thing I spent a lot of time taking care of, is also way off the curve. And then its funding is related to knowledge, because that's how it works, and that's the graph on the right side of the screen in terms of publications per mortality rate. So we don't know as much as we should, and that's kind of like, I think, yeah, where we are. Hey, go back. With firearm injury epidemiology. This is something I could go on and on and on about, but I will stop now. And say, this is my first question, is like, so this is quotation is from a article by some colleagues that I think states like the positive version and maybe sort of the most straightforward one. It is our ethical responsibility as physicians to advocate for robust gun violence research to address this growing public health epidemic that claims tens of thousands of American lives a year. Like, that feels true to me. But it's also true that, like, when I think about these other questions, who benefits from firearm violence? Who benefits from the treatment of firearm injury? Who benefits from firearm injury research? There's other people in all those categories, but I am in all those categories because my job is to take care of people with other kinds of illnesses and injuries too, but to take care of people with injuries due to firearm violence. Like, I get paid a lot of money to do that, like, really. And so do my colleagues. My students and residents and fellows learn from the suffering of people around us. So this is always true in medicine. Like, it's one of the really, I don't actually know how many of everybody is clinicians or not, but we get our learning and our career satisfaction out of terrible things that happen to other people. And like, the thing that I say is, I'm so sorry that this is happening, but I feel honored and privileged to be here to help in that circumstance. It's true too. It's also true that, like, if this problem went away, like, I'd have to find something else to do. And it's not like I'm going out and shooting people, obviously. And it's not like I'm consciously perpetuating this problem, I don't think. But it is true that, like, I have a certain set of incentives and that have to shape the way I think about things. That the health system, by the same token, has a certain set of incentives as far as trauma is, like, not a really, well, that's a whole thing. Violent injury is not a particularly well reimbursed form of care directly because it's structurally determined to impact people who are structurally determined not to have good paying insurance, right? Like, it's all part of the same thing. But the health system gets trauma center funding from the state, which is another thing. And the health system gets a certain kind of, like, credibility and cachet and community acceptance. So there's like a thing. We get visitors. We get visitors from Sweden who come here to learn about taking care of gunshot wounds, just in case they ever have one there, because they don't. They're actually, the rate of firearm violence in Sweden has really increased recently from it's like quadrupled from like 2 a year to like 8 a year. It's like, they're really worried about it, as they should be, right? Like, we should be worried about every single, not kidding. We have this wonderful program, this military civilian collaboration going on right now. It's called the MSHP program. So we have a Navy team that's stationed with us for a couple of years to keep their combat readiness up, to keep their skills up, to care for people with serious violent injury. And they come here because it's a reliable location where they can practice those skills. And that is, like, so dismal. You're looking at me like that's disgusting, because it is, right? It is, but it makes total sense from, like, I don't know anything about combat readiness, but it makes sense. And it makes sense for our Swedish. I'm not saying, like, they shouldn't come and learn. I'm just saying, like, it's gross. And the same thing I think is true to some extent in research. So like I get to come here and give this talk. I get to get grants. I get to get like my, I get whatever. I get like a lot of professional, well, I'm not like so incredibly successful, but like I get like some professional success out of doing this stuff. And not only am I not someone who's been shot, but I am also like a wealthy white female physician who's like structurally at extremely low risk of directly experiencing these consequences. It's not like I don't care about my patients, but they don't look like me. They don't look like me. That's not true for everyone I work with. It's a little bit structurally true for any physician, like no matter where you start off, by the time you're a physician, you're kind of in a different economic class. There's nuance to that. That's not the point of this talk. But we live in a community, and so and one thing here, right, that I think I'm going to talk about later, or at least reference later, is the University of Pennsylvania and the University of Pennsylvania health system are by far the largest employer in our area, right? So it's not at all uncommon that we have patients who come into our trauma bay whose mom works in sterile supply, or who's whatever. That's a specific example, but who are in our larger health system family. We've had people on our trauma care team, and I'm not going to get more specific about this, who have seen literally someone that they know, literally a member of their family, literally die in front of them, right? Like it's extremely acute problem, and it's extremely acute for people who are not me. I get all this benefit out of it, and like I think I'm helping people. Like I'm not like, but like, what are we supposed to do about that? And I don't know. This is not the same thing, but this is a really interesting, imperfect, but very interesting article about this concept of health equity tourism, which is like not the same thing, but I think there's some relevancy here by Dr. Lett et al. From a couple years or so ago. And some of the principles that they kind of put together in this study are these questions, like who is represented in this study? If you're sort of thinking, and I think it's relevant just because like sometimes we don't think of firearm injury as like in the health equity context. It's actually hard to look at equity issues within firearm injury because the whole thing is such an enormous disparity. Sort of opposite from a lot of studies. So they're talking about who's represented in this study, and is it statistically convenient to ignore underrepresented groups and marginalized groups? We have sort of the opposite phenomenon. I think it is worth thinking about how can this work cause harm? Are we coming to conclusions or designing interventions that are going to hurt someone? I think it is important to like think about positionality, and I'm like thinking about it. It's probably important to do something more than think. I don't fully know how to do it. I think a lot of the solutions that we come up with for this kind of problem have to do with collaboration across disciplines, but also within and without academics. So some form of community participatory research. It is essential to work like this, but I also think it's certainly not easy. And it's certainly not easy on the sort of usual academic timeline, and the way that grant funding happens, and the way that publications happen, and the way that the reward system is structured. But it's also like not easy, like to figure out who is appropriate to collaborate with, whether the people who might be part of a community who have the time and energy and interest in collaborating with your research project are actually the best to represent the people who are most at risk, and how you go about that, and like how you, and there's like a thing about making sure that you put your community collaborators on the paper, and that makes total sense to me. But that's just like, I'm an academic and I like to have my name on papers. It's like, and some people that I've worked with also value that, but there might be other things we should be doing. And I do like this bottom thing where they're talking about the difference between sustainability and urgency, and how like sometimes it feels like as researchers, particularly maybe as white researchers, we like suddenly notice that there's some problem. And they're talking about health equity tourism. There is a similar phenomenon where, like I showed you this graph before, we do have a new set of available funding in gun violence research, which is hugely needed and long overdue, and has been prevented by federal legislation in a way that is unique to this field. But anyway, but it does result in this sort of like enthusiasm, which is good, but also bad, maybe, or potentially harmful to say like, I've discovered this urgent problem and I'm going to bring my totally irrelevant expertise to this topic that other people have maybe been trying to work on for a long time. And I like this quotation here: rushing in frames populations made vulnerable by systemic discrimination as incapable of directing their own liberation. It's not that it's not urgent, it's just that it's also not new. I think this is the end of what I have to, that's the end of what I have to say about this. So I'm gonna pause and see if you can help me figure out how to do work that is valuable.
I'll chime in. I mean, I think it's good to ask these questions. I think you're right to notice that your work in this space is not different from other types of medicine, right? I mean, people who are suffering from non-traumatic injuries, right? Cancer or other or HIV or other things that have major social determinants behind them, right? People build their academic careers as clinician researchers on that work. And the way to prevent harm is to answer research questions that will help improve the health of the populations that you care for. So certainly there is this professional benefit from the work that you're doing, but you're not doing it from what I can tell, right? You're not doing it for that professional benefit. You're doing it because you think this work is important and people are in need of care and services, and the policy interventions that your work provide unique insight for. So I'm interested in whether other people have that same kind of reaction.
No, and I appreciate that. But when I say like I'm serious, like it's not like about me and like whether I feel good about my work, which I sometimes do and sometimes don't. You know, that's normal, I think. But it's like, I don't know, I think this is a problem. You're right. It's not different from many other things. I don't think it would be better for me to like find a disease process that uniquely affects like people just like me, right? Like that's just like me have too much research done. Like so.
I mean, I think in general, right, those of us who are academics who do policy relevant work do it because we hope that the problems that we're working on will be solved. But we recognize that the problems that we're working on are very large problems. And so even if we are successful, we're kind of chipping away at a broader problem, right? So wouldn't it be wonderful if gun violence went away completely, right? But it's such a multifactorial problem that it seems unlikely that any one of our careers is going to fully resolve the issue. And other things will pop up, right? I mean,
Sure,
not
too bad. All right, I'm gonna keep going, talk about some other stuff. Something that comes up a lot in this work that I think is probably applicable in some other contexts is what does healthcare really do? And is it just providing acute and post-acute care to, in my case, injured individuals, or is it doing whatever is necessary to promote health, or is it somewhere in between? This is a mission statement of Penn Medicine. We are dedicated to discoveries that advance science, to outstanding patient care throughout the world, the education of physicians and scientists who carry on our legacy of excellence, blah, 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 strive to improve the health and well-being of people through research, education, clinical care, and community service. And I think that it doesn't answer this question. If you look at the website where I stole this from yesterday, like the thing that's immediately below that is this, is committed to the boundaries of pushing medicine. But I think maybe not always in the way that I was thinking about it. I don't know. And this is a shorter thought, but the individual, this is like a psychosocial, socio-ecological model in which the individual is in the middle, but they're surrounded by relationship and community and society. The individual is really small. These are like some different types of interventions that have to do with firearm violence specifically, and like medical care is pretty small. And have people seen this Frieden pyramid too. It's about the relationship between individual effort, which is high at the top of the pyramid, and population impact, which is big at the bottom of the pyramid, and clinical interventions and counseling and education, which are a lot of where our efforts are expanded, are right at the top, doing not that much for not that many, with a lot of effort. So that the most prominent cause is not necessarily the best target for interventions. So this comes from these thoughts about car crashes. Drivers are the cause of most crashes. That doesn't mean that you can fix the drivers. We fixed cars and we fixed roads and we made crash mortality plummet. And there's maybe some kind of lesson there. This is William Hadden, who was kind of the guy who brought science to injury science, and described injury as the only substantial remaining categories of human morbidity and mortality, still viewed by most laymen and professionals alike in essentially pre-scientific terms. He was not a nice guy, which maybe you can tell from this quotation, but he was really committed to this and did amazing work. So that's nice as well. Luck, chance, accident, and other extra rational notions still survive. And he developed this, the point of that was to get to this Haddon Matrix, which is kind of the mainstay of public health thinking and injury. There's the before the incident, in this case, it's a gun being fired, during the incident, and then after the incident. And this is kind of a version of that for firearm injury. And just again, medical care, it's puny, right? It's like, it's not much. And it's after. And I just had to highlight, avoid the presence of firearms in risky situations, because I don't know what a non-risky situation is really. Such a gun safe. Unlocked, locked and unloaded. Anyways, so I just totally made this up. And so don't hold me too much to the placement of all these little boxes, but this is some relationship between public health income and for sure the health system is supposed to be doing it. So we're definitely supposed to provide medical care. There's been a lot of work on screening for firearm presence and risk, which I think is valuable, maybe providing secure storage devices for firearms. Alcohol and substance use are heavily related to violent injury. And that's probably in our purview. Restrictive firearm policy is, I'm not actually sure sometimes where it goes on the blue line, but I think probably not a lot of people would argue that the health system has a role in certainly implementing it. Should health systems be advocating for it? I don't know. It's pretty difficult to do legally, and also whatever firearm policy is a morass. We can talk about, but public education, and by this I don't mean public education about firearms. I just mean we're talking about the root causes of violence. If you could fix our school system, you would have fixed a lot. If you could provide, if you could decrease poverty and provide reasonable employment opportunities, if you could make housing available to people, all of those things are some of the many things that would address some of the root causes of violence, and are probably sort of out of the realm of the health system, except to say that we are a huge employer in this area. Do we always think about those relationships? We don't always think about them. I think there are good work being done in the institution, but we could probably do more. An increase of 10 community building organizations per 100,000 people, I'm pretty sure that's the statistic, decreases violence and homicide by 9%, or 9% violence and 6% homicide, I think, which is interesting as a set of numbers, but I think also really meaningful conceptually as far as what keeps people safe. Where does I don't know. The health system have a role in youth development, which is sort of part of that, alleviating poverty. There's a lot of work in this area on the greening of vacant lots, which is pretty powerful violence prevention thing. The university has invested in that. The city has invested in that. It's the health system invest in that. They actually have. Does that make sense? I don't know. I like it. I spent a lot of time working on what's known as hospital-based violence intervention programs, which are based in the hospital. That's why it's called that. That are sort of wraparound peer mentorship and case management for survivors of violent injury, with the goals of optimizing holistic recovery. I think is the most important goal. A goal that's talked about a lot is preventing recurrent violent injury, which is also important. And I say these are based in hospitals. I think they have an important impact. Talk for a long time about the evidence on that, but we won't. They're generally not directly supported or funded by health system, our systems. And it's a little bit outside of like what we consider to be post-acute care. The people who are providing the care are not healthcare professionals as usually conceptualized. So the federal government has made it possible for states to opt in to the following situation in which and to use Medicaid dollars to reimburse violence intervention work, which I think is potentially a huge paradigm shift and really important and really interesting for this kind of care. States do have to opt in, and that process is happening real slowly across the country. We think we're making a little headway in Pennsylvania on that as well. But yeah, I don't know. Oh yeah, okay, good. That's all I have to say about like where the health system ends. So I'm gonna pause again and see, right? Because like I think some of this is cross topic, right? Like all of these things affect lots of different health, lots of different kinds of health. I mean, I think violence is easy to talk about in a way, like it's so obviously and so acutely structurally determined, but so is everything else. So is every other health problem. I don't know. What should we? Are there like things we should definitely not do? It's like too much. I'm just gonna say one more thing and then I'm really gonna pause. Just say like a lot of this I'm framing as like I want the health system to do more. And I do, and I want our fake nonprofit health systems to act more like community serving organizations and not hoard so many resources. But I'm not sure that people always want to come to the hospital or always want to see the health system or always want to see Penn, like, or that the locus of control should be with us. Like that's extremely not always true.
Very interested in this, and thank you for what you've shared so far. And I wonder what a hospital-based suicide intervention program might look like. Hearing that, I know that gun based suicide is often very lethal, but other times there are warning signs and precursors when people are hospitalized or do visit their doctor or doctors are aware. I wonder if these factors are similar, or like a chart like this would look similar for something like that, or if there are opportunities for healthcare workers and researchers to engage at this level in order to prevent such a thing. That makes sense.
Yeah, it does make sense. And I think there's a lot of work done in that area about which I know only some, but I'll say a couple things. But I think sort of maybe what you're hitting on is something that I think about a lot, which is like there's a person out there who's at risk for something bad happening. And they somehow come into contact with our system. And like, are we maximizing that opportunity in the healthcare system? And in violence prevention, this comes up a lot because a lot of people who do end up dying of homicide have had contact either with us or with the criminal justice system, which is a totally different thing, but still it's like they've had a point of contact and it feels like a missed opportunity. It is. And I think that that's true because I have like a different set of research interests that's about like using the acute care hospitalization to get people enrolled in insurance and connected to primary care, which is a little bit more like in-game. But we can maximize a little bit more these rare opportunities for people who have poor access to or various other barriers. So the thing I know most about is lethal means screening and counseling. Because suicide deaths can be related to long-term distress, major mental illness, not always that need deeper intervention, right? But it's also true that the actual suicidal impulse in most people is very short. It's less than a day, and about 3/4 of people, less than 2 hours, about half of people. And so, even people who attempt suicide, if they survive an attempt, 90% of people are long-term survivors. Right? So there's a myth out there that if you take someone's gun away, for example, they're going to find another way. And it's just not true. It's not borne out in the evidence whatsoever. And I think that's a really hopeful thing, that yes, we need to treat the underlying thing, but we can save people's lives and get them that second chance if they're separated from those very lethal means. So if you put nets on a bridge, suicide rates go down on that bridge and they go down in the community, right? You don't immediately go find another. Yeah, so lethal means screening, and secure storage device distribution has been a lot of where the effort has been in this.
No, that's.
I think, yeah, no, I think there's a lot, but I think there's a lot more to say that I don't really know as much about sort of a similar thing, like bringing suicide risk screening and prevention into primary care settings and emergency department settings. Like, can be very powerful.
Well, what if you know how like when you go to your primary care, I actually dealt with the doctors and Stephanitas, who's my work partner in the last couple of days, and they asked me the serious questions, right? Like, are you afraid?
Yeah.
How about, do you have a gun at your home? Because then you can have conversations, especially I think people who have children have no idea that they saw even a piece of paper with that statistic on it. You know, they might think differently, or they might cause a conversation between partners, or, you know, some sort of, because what are those questions for anyway? Like, do you smoke? Do you do that? You know, are you going to offer me something if I say that my favorite is, are you depressed, or have you been depressed this week? Hell yeah. I think most people in America are pretty much depressed once a week. So, you know what I mean? Like, I'm not sure what the interventions are that happen after those questions, but I certainly get asked a lot of questions that I have no idea what the answers are.
Well, so this is so, yeah, so firearm storage counseling is a really big topic. There's a lot of work, there has been a lot of work, and there's a lot of ongoing work about specifically what you just said, doing that in pediatricians' offices, because people love to talk to pediatricians. Pediatricians are very non-threatening and very it's a little bit easier to talk to people about their children's safety than their safety. Easier necessarily. I don't want to say that it's an easy job in any way, but it's sort of an area of openness. And yeah, they'll screen for seatbelts and for all sorts of different things. And more we're asking people to screen for presence of firearm in the home, and to do some counseling, not usually asking people to get rid of the firearm, although ultimately not having it makes it no risk. But about storage. I think secure storage is really meaningful for unintentional injury and death, which is unintentional death is rare. Unintentional injury is pretty common. And when it happens, it's just so devastating, right? Like, we've all seen those stories of like 2-year-old shoots 4-year-old, right? Like, it's of all these things that are all the worst, it is one of the worst that's out there, right? So it's good for that, and it's good for suicide prevention. It's good for youth suicide prevention, because the vast majority of youth who die from suicide with a firearm get it from their home, or the home of someone they know. They don't go out and purchase it themselves. Every once in a while, right, there's someone who's really committed and will, but in general not. There's always a component of PV. So secure storage makes that big difference. There's work on counseling on in nutrition's offices, in primary care. I will say I am not a primary care doctor, but I have a great deal of respect for them and for all the things that they're asked to do and required to do, and for all the burdens that we put on them that we're not doing somewhere else. So that's why they're asking you all those questions, because they're all important. And I think all those once a week questions, the answer is once a week is not a positive screen. So if you screen positive, you would get some intervention.
To be honest to me.
Well, I mean, there's always a question with any of these things. Are people going to be honest? Or maybe more honest than you would expect. So there are interventions, and I think that's one of the reasons, one of the barriers for physicians asking about things like firearms. They think that people don't want to talk about them, and they don't know what to say if there's a positive screen. So if we can answer those questions for clinicians, which we can, then I think, we can improve that. And about 60% of people are willing to talk to their doctor about firearms, which is at least about firearm owners specifically. And it's a larger number are interested in talking to their kids' pediatrician. I think people most want to talk to law enforcement about it, which is interesting as well. as far as expertise on firearms and firearm storage. So I think that's what it is. So there is an opportunity there. That opportunity is being used. It's not universally used. My daughter was at the pediatrician this week. They won't screen us for firearm ownership. I was going to write them a strongly worded note.
It's not CHOP pediatrician.
It's not a CHOP pediatrician. I know the program at CHOP, and I know one of their next missions is to kind of try to disseminate to community pediatricians. It's also, I mean, it's true that we don't have firearms, and it's also true that injury prevention researcher, whatever. But although some of my best friends in injury prevention are firearm users. Anyway, cool. Other thoughts?
Can you say a little bit about your own research in this?
Yes. So far. Okay, so I am going to do that. I have all this stuff about law enforcement, which I'm going to skip at least for now, because I do kind of want to talk about. I'm going to skip a bunch of stuff. I knew I was going to overload myself, but I kind of do want to talk about some things that I'm working on and see what people think. That these are kind of like open topics that I hope are in. And then if they're not, we'll go back and talk about that other stuff, because obviously I can go on for a long time. Brief story on law enforcement is I think there's two things. One is that individuals who've been injured, particularly due to violence, although also other individuals for lots of different reasons, may often come into contact with law enforcement during their clinical care. And I find that to be a real big challenge because people are not necessarily in a position to either know or sort of defend their own rights. If a police officer comes up to question you on the street, you at the very least have the opportunity to try to walk away. That's not true when you're in an emergency department bed. So the whole, it's sort of legally treated as an extension of the public space, the street, but it's sort of really functionally not. People may be in pain, maybe on pain medications. But the thing that worries me the most, I know it all worries me, but one of the things that worries me the most is the way that we have enough problems in medicine with structural racism, with discrimination, with all our own problems. But when we then the patient can't tell who's the doctor and who's the cop and whose questions they should be answering and where the information is going. And when we can't tell, when we have this increased assumed criminality, we think if you got shot, you must have done something to deserve it. We don't think that explicitly, right? But it's there. It's there. And I think that the presence of law enforcement amplifies that. That's the one thing about law enforcement. Then the other thing about law enforcement in this work is we talk about firearm injuries, public health problem. So been a sort of catchphrase for the last several years. And part of that is just in opposition to saying firearm injury is just a criminal justice problem. A lot of the sort of default solutions are law enforcement. When people talk about policing, or people talk about defunding the police, which is not really what I'm talking about, not really what I'm planning to talk about. I think there's the assumption that sometimes that policing can cause harm, but that there's benefit. But a lot of the benefit is not particularly proven. And I think it's really important in this area when we're talking about there's sort of known harm associated with intensive policing, particularly known disparate effects on marginalized communities. Black communities in particular, other communities of color, that getting some sense of the effectiveness is important. And then I also have this question of even if it's effective, is it okay? I don't know. And I'm skipping this idea of root causes and individual interventions, which are sometimes in tension. I think the best solutions, we can find something that does both, but that's hard. Anyway. So here's some things that I think are interesting. So this is upcoming research project number 1 that has to do with mobilizing social media for violence prevention. So social media is an integral part of daily life in the United States. I think that's maybe intuitively obvious. There's some numbers that support it across demographics, across ages, across urbanicity, across whatever. everybody uses it. And there is a growing body of evidence that online conflict can contribute to violence in real life. And it seems like some of the mechanisms by which this happens are by sort of converting an interaction that might have been ephemeral to something that's now recorded and permanently preserved, and it's on the internet and people are commenting on it. So it's not only preserved, but it's also, maybe it was a private interaction that you could have dealt with privately or forgotten about or whatever. Now it's public and now people are saying things and now you have to say something. And there's an increased pressure to respond and there can be some escalation in that context. So my partner is a K-8 arts teacher in Kensington, and they started learning jujitsu over the summer to get better at breaking up fights among middle schoolers, which is a little bit of a grim statement about our public education system as well. But the reason that I'm talking about it now is to say that, so they do, and it's like actually has given them a lot of safe skills for breaking up these fights among middle schoolers. And so that's good. And it's also true that the middle schoolers are not supposed to have their phones in class, but they do, and they like to record each other fighting. They like to post it on their Instagrams and like, and it's like not cool to have a recording of your art teacher breaking up your fight. So in addition to kind of breaking up the fight, they have also sort of broken up that form of transmission, which they did not do to serve my research, but I think there's a thing there. But I do like a lot of social media stuff and I like it. I mean, I don't always like it, it can be toxic, but it can also serve as a place of refuge, of connectedness, can give room for grieving, emotional expression. I think it's particularly valuable for marginalized individuals and groups, like for someone who grew up queer on the beginning of the internet, right? Like the world has changed. I think that's valuable. Anyway, so I think there's a lot of there potentially, but the role of social media-based intervention and violence prevention is yet to be established, and we're going to try to establish it. I kind of got interested in this issue because I had patients who said things to me like, I should have known this was going to happen. I saw it on Instagram, which is spooky. And so I started reading about it. And when I say a growing body of evidence, what I really mean is the work of Dr. Hadden, who is really the leading scholar and in this space and a wonderful person who conveniently was recruited from Columbia to Penn this year. So I get to work with him and that is super cool. As well as Dr. Joe Richardson, who's down at the University of Maryland and our growing research team. So the first thing, and this kind of goes back to something that I didn't really talk about, that I wasn't thinking about, that we can always just sort of refer to, of like the ethical, there's some ethical issues in here, which is sort of the minority report thing, sort of the surveillance thing, sort of the like, even though we're maybe talking about public posts or whatever, people don't really think of the internet as public a lot of times. And like, to what extent is it okay to be using what people put out there in some form of surveillance? Like we think we're doing it to help them, but like, I don't know, especially heavily surveilled populations. So this is our first study that we're trying to do, and I'm just literally copying my specific aims because we're literally like just about to start. Very excited. So we're going to spend some time talking to community organizations and experts in the violence prevention space, which again goes back to my concern about like who represents community and what does that mean about this relationship. What are people seeing? What are people doing now? And specifically, and this is the first time I've ever like put the word ethics into a proposal like this, so I thought it was right to bring up in this forum, like what is the potential for ethical intervention in this space? Can we follow folks on social media, and if we learn to recognize signals of distress or signals of escalation, is it ethical to use that information to intervene either online or in real life, and intervene in what way? I would say it's probably definitively not ethical to use what someone posts unless it's like a really direct threat to like call the cops, which I think would probably not be an effective intervention anyway. But like, where's that gradation? Like, I don't know. I think it's really interesting. I'm really interested in survivors. That's who I spend my time with. So social media engagement, like, are you like before your injury, but also after your injury, you're kind of socially isolated. Maybe it's been COVID, but also maybe you're stuck in the hospital, you're stuck at home recovering. Is it a source of connection and refuge and emotional expression? Are you just doom scrolling? Are you increasing or decreasing your risk of being involved in retaliatory violence? I'm really excited to talk to people about that. And then we're going to try to develop some type of toolkit to help people, I don't know, test some interventions. I'm excited about it. We haven't done any of it yet, but I think it's going to be very cool. We have some allied proposals that use computers in ways that I don't understand to like collect large amounts of data and try to work with community experts to translate and interpret some of the content, because a lot of the risk in this area, there's so much risk of being stupid in reading social media. And some of that has caused real harm to people. So when I talk about like sort of trying to distinguish from policing, I think without being naive, I think it is really important because many, maybe all police agencies are doing some kind of social media surveillance. Exactly how and exactly to what effect is not well known, but there have been some prosecutions based on social media content that turned out to be like quotations from song lyrics. Not that quotations from song lyrics couldn't also be used in a threatening way, but like you see, like we can be so dumb from the outside, and you don't have to be very far outside of an insider conversation because the language is very local and changes frequently. And so figuring out how to kind of navigate that. All right, cool. I'm gonna stop now. I'll take thoughts or questions.
So are you thinking, excuse me, thinking of like partnering with Annenberg and using their, they collect lots and lots of words and posts and things from social media, and they try to, I know they've done studies where they've tried to predict when someone's going to relapse based on their Facebook posts. And I mean, is this?
Yeah, so for take two with like the sort of computational part, yes. For this part, this is sort of individual and sort of focus group interview type stuff. But yeah, I think kind of learning how to interpret that context, that content in the appropriate context collaboratively would be really cool and interesting. And I think there's a real question as to whether it's actually doable in any useful way, but it's worth trying.
What kind of community experts are you getting involved with this study?
Yeah, so like literally sending some emails about that this morning type thing. So I mentioned this briefly. I work with our hospital-based violence intervention program here at Penn. There's a citywide coalition of programs like that at every trauma center. So that's sort of a set of people who are good to work with. There are a lot of organizations in Philadelphia working on violence prevention one way or another. For this, we're particularly interested in people who are focused on supporting survivors, but not exclusively. Another thing that I sort of slid by is one of the most prominent strategies for violence prevention right now is violence interruption or cure violence, and with trained, credible messengers work with high-risk individuals at times of high tension to diffuse conflict, promote conflict resolution, and the hope is over time sort of change community norms for conflict resolution. There's some pretty good evidence for those programs. There's plenty of criticism of the evidence for those programs, but it's a very prominent and I think useful model. So there's a bunch of organizations in Philadelphia that use that model one way or another who we're hoping to work with and learn from for this, and who would be sort of ideal people to deploy this kind of strategy if it ends up being a thing.
I have another question. You might not know the answer to it, but do you see these kind of, we've been talking a lot about hospital-based interventions. Do you see them mainly in academic hospitals, or do you know if they're still present in like community hospitals, healthcare centers? Is it more common in one versus the other?
So hospital-based violence intervention, so lots of hospitals do various things, and I don't know the answer in that sense. Hospital-based violence intervention programs are variable, but sort of a specific thing that's focused on supporting survivors of violent injury. They've been kind of growing in number over the last 20-ish years, and are not present everywhere, but are present in a larger and larger number of hospitals. They are not necessarily academic centers, but they are usually designated trauma centers. And those things are not always the same, but they do have a lot of overlap. And if I had to guess, I would say that they're more likely to have an HVIP at a trauma center that is also academic, but not exclusively. One of the first ones, COP was one of the first ones, and a program called Healing Hurt People, which is now kind of dispersed, but was formerly founded at Drexel when Hahnemann was a hospital. Was one of the first, as well as, you know, as along with some partners around the country. So they probably are more academic than community. I think there are probably some non-academic centers and some hospitals that are not designated trauma centers that do care for a disproportionate share of people who are violence and probably do not get this kind of programming as much.
Can you say a little bit about the last line here, follow ethical parameters for social media driven violence prevention work? So what types of things are you thinking? Privacy related issues, interaction with law enforcement? Maybe you could just elaborate a little bit more about.
Yeah, just the sort of stuff I was wondering about before is like, is it even, we may do stage one and we may get the feedback that like, this is a bad idea, that we should not be looking at people's content in this way, and we should stay out of it. And like, I'd be annoyed and I'd have to figure out how to spend the rest of the grant funds. And I'd be disappointed because I'm really interested in that area, but I think I'd have to take that, right? Like, so that's one outcome. I hope that's not the outcome. I hope that people tell us not that, but that like, yes, look at it. And informally, that's what people have said, right? But I think there've got to be some parameters on it. How, like, who's going to look at it? How is that going to be protected? How is that going to be communicated? What interventions would be okay? Is it okay to intervene in some way online? Is it okay to talk to people online? Is it okay to approach people in real life? Is it okay to approach the person who posted? Is it okay to approach the person or people they posted about? Is it like, you know, like who can do that approach? Who can we get involved? Can you call someone's mom? Can you call the cops? You know, like, can you call a local community organization who that person hasn't necessarily consented to participate with? I think these are all like great. So I don't know the answer, but I'm hoping to learn something about it.
And the you in that scenario is the health system or like anyone, right? I mean, it could be a school district, it could be.
It could be whoever.
Anyone.
For the point of this, for the, you know, for right now, it's like us, the research team, right? If we're going to try to develop something. But yes, if we say we like develop something that works, that would be cool. And then you figure out some way of disseminating it. Then, right, like, can you disseminate it to, yeah, right. What should happen when Maria's 8th graders are posting Instagram videos of each other fighting?
So we have time for probably one more question before we're at the end of the hour.
Great.
I think it's interesting how you seem anti-law enforcement doing that, but you're pro you doing it or other people doing it, right? Do you think that law enforcement has no parameters? You wanted to put these parameters on yourself where would it be, when would it be appropriate? But do you think law enforcement isn't thinking, would this be appropriate to save someone's life or to solve a crime or to prevent future violence?
Yeah, I don't know. I'm not going to try to speak for how law enforcement officers think about their own work, but I am going to speak to try to say something else, which is that I'm extremely not interested in punishing anyone for anything, personally. And I'm pretty skeptical of the role of arrest and incarceration in violence prevention. There's going to be some scenario in which it is effective, but I think that's probably the minority, certainly in the long term and probably even in the short term. We have a big problem with mass incarceration in this country, which I think is causing a lot of harm and not a lot of good. So I'm very hesitant about approaches to violence prevention that rely on carceral strategies.
So you wouldn't report things if you found out something that you could stop something, or because, I mean, when you're doing these purviews of people's social media, I'm sure you're going to see scenarios where and prevention might be required.
Yeah, so I think that's exactly it. So first of all, I'm not sure. That's the research question, is like, are we gonna see something that tells us? But exactly that last thing you said, intervention is required, but what is effective intervention? Is effective intervention identifying someone and arresting them? Like, maybe there might be situations in which that's the case. Is there something equally or more effective and less harmful that we can do? I hope so. I think, I don't, you know, I think there are, there does tend to be this assumption that like law enforcement is the go-to. And I just don't know that that should necessarily be the case. I did skip over some interesting stuff about a recent evaluation of a program called Group Violence Intervention. That was just a program that was recently evaluated by a Penn researcher, Ruth Moyer, in criminology here in Philadelphia, which is, I think,
I'm sorry, I'm just gonna pause you again, just to say if anyone has to
Sorry,
go.
sorry.
Group violence intervention, but
I'm sorry.
But others are welcome
No,
to participate.
Because I think it's an interesting, I think a lot of law enforcement is not evaluated the way we evaluate evidence in medicine or healthcare or other fields of science. I think that's a very interesting example of where they tried to do it and found some useful stuff, which is imperfect, like many other. But yeah.
Okay, well, thank you very much, Dr. Kaufman.
We didn't do guaranteed income.